Hello, everyone. Thank you so much for joining myself and Joseph Tomino, CEO of Grassi Healthcare Advisors, for this micro-learning session, SNF Sustainability in a Post-COVID Environment. Joe, please take it away.
Thanks very much, Lauren, and welcome everyone. Well, as you know, we've been through a very hellish situation with the COVID pandemic, and it's really impacted everyone significantly. What we're seeing across the country is that most providers are between 20 and 40% down in revenue, mostly related to the fact that we have vacancies. Many are being sustained by PPP and HHS funds, but those are going to go away as we move into 2020. It's estimated, I was on a call the other day with the Turnaround Management Association, and they were looking at some national data. It's estimated that at least 40% of SNFs are going to fail within a year, which is a scary thought. Already before COVID, we were looking at some of the Medicare cost report data, and between 50 and 75% of facilities were already financially strained. So it's not a surprise that when you go through a period of time of 20 to 40% downturn in revenue, that you're going to have a significant number of failures. The only segment that's experiencing any merger and acquisition growth right now is hospice, but we're expecting consolidation of facilities to grow as facilities are having trouble staying solvent. Also, when I talk to a lot of bankruptcy attorneys, they're expecting to see in late fall and early winter a significant number of bankruptcies of healthcare entities, of which nursing homes will be a significant number. How do we get through what comes next? Facilities are looking at a significant vacancy factor due to fewer admissions from hospitals related to shutdown of elective procedures, the loss of long-term residents. Sadly, many of them passed away due to COVID-19. And we have this resulting family reluctance to place relatives in skilled nursing facilities at this time, which is a double whammy, because not only do we have the vacancies, but then it makes it harder to backfill the beds. Government funding is a help. The PPP loans, for those of you who were able to access the PPP loans and met the criteria, that was a big help. The HHS CARES Act relief funds was helpful. There were several tranches of that money. There was one that was based on your previous year Medicare revenue. There was one specifically for skilled nursing facilities. And then, basically you should be getting at least 2% of your patient services related revenue in HHS CARES Act relief funds. There's a deadline of September 13th, I believe, for applying if you did not. And you should take advantage of that if you haven't already. In New York here, we have the FEMA loans that are specifically for not-for-profit nursing homes, the SBA disaster loans, and for larger facilities that weren't eligible for the PPP loans, we have the Main Street loans. So as I talk to CFOs of skilled nursing facilities, many of them tell me that if it wasn't for these sources of funding right now, that they wouldn't be solvent, but that they're concerned that if the census drop continues into the new year, which we're anticipating it will, they're not sure how they're going to make it. Through this time, cash flow management is really, really critical. And for this reason, you should have a really granular cash flow projection on a weekly basis and have this projection out for the rest of the year. And actually, I would do it for 6 to 9 months at least. Anytime, as a CEO of facilities, whenever I've managed struggling facilities, I've found this tool to be really critical, because it helps you decide how to manage cash and how to decide when to make your payments. What I would do is have a weekly meeting with my accounts payable team, my CFO, and I would update the projections, projections of revenue coming in the following week based on the census from the prior week, and then update the projections from the prior week with the actual numbers that came in. And you estimate what your revenue is going to be by looking at the census. The average revenue per payer, and you can plug in that number with when it would normally come in. So if it's, say, Medicare revenue, and you know it's going to come in 30 days. You plug it in 30 days. And then you would make adjustments to your payment schedules based on when you're going to have the money to pay certain certain bills. And let's go through this a little more. Typically, it's set up, in turnaround situations. You'll hear this term 13-week cash flow projection. I think 13 weeks in our situation right now is way too short. I think it's better to do it a 6 to 9 month projection for two reasons. One is you have expenses that pop up that are not regular expenses. So, for instance, workers' comp premiums due, certain union payments that may be due. So those things need to get plugged in, and you need to plan for those. The second reason is that with doing it over a longer term, you can do some scenario planning on the revenue side. So you could say, let's look at the next 9 months. If census stays the same and the revenue stays the same, let's look at, let's say revenue census improves. What would revenue look like, and what would our cash flow look like? Or if we have another episode of shutdown, and we have to even lose more beds, what would the scenario look like in that scenario? So by doing it longer term, you can play around with different scenarios and see what your long-term picture is going to look like. Now, I put this up here as an example, and it really amazes me when I work with facilities, how many facilities just do maybe a monthly cash flow, and they don't go through the rigor of doing a weekly cash flow. And it is a lot of work, but it's really critical. If you don't do this, it's like flying a plane in the fog with no instruments. What you basically have at the top is your revenue. In this case, I have, this is just very simple, but normally you would have all your different payers, Medicare, managed Medicare, commercial, workers' comp, self-pay, whatever, up there at the top, and you have your total revenue. And then you have your payroll taxes, your mortgage, your benefits expense, your supplies, and supplies by specific vendors. I list out on this each vendor and what we owe them when. And then, as you see, you have your revenue at the top, the expenses on the bottom with the balances. Now you can see in this example, in week 3, we're looking at a negative cash flow. So if we don't slow down on some of the payments of things that we're paying in weeks 1 and 2, when we get to week 3, we're going to have a problem meeting that. So this helps you make some adjustments in how you time payments. Now, of course, things like payroll taxes, mortgage, you can't play around with. In the supply area, you can stratify things and have your more critical things like medications, food, and so forth higher priority than other things like architect fees or fundraising expenses, things like that. So, and you also can better negotiate with people if you owe them money. Let's say you owe a vendor $1,000 and you can pay them $500 this week and $500 in 2 weeks. You can call them up and say, I can plug you in. This is how I'm going to pay you. Is that okay? That's far better than waiting for him or her to call you and say, hey, I'm looking for my $1,000. And they're not going to be as amenable to having an accommodation made. So use it that way as well. So our prescription for how to deal with the situation right now really is threefold. We come in and do an assessment, and this is what you should do as well. Look at your situation and look at 3 basic areas of opportunity. One is you want to look for opportunities and plan for cost savings. You want to realign the expenses to your reduced revenue, your reduced volume. You want to identify opportunities and plan for increased revenue. My feeling is you can never, ever cut a facility into profitability. You have to look for ways to increase revenue, and in this case, backfill some of those empty beds and get them at a good payer mix, maybe more Medicare than Medicaid if you can. And then identify opportunities and a plan for access to capital. So we'll go through each of these in a little more detail. aggressively address that occupancy. Rebuild your relationships with referral sources. Get out and communicate with them. Now I know it's difficult right now without being able to make in-person visits, but you can do things virtually. I do the same thing right now with my clients. I set up regular calls, Zoom calls. I sometimes have coffee with them. I set up I'll send them a bagel and have coffee with them. Every Wednesday night, I have a virtual cigar lounge, and I keep in touch with my clients and referral sources that way. So, find out whatever's appropriate for your usual referral sources. Set up some way of keeping in touch with them, letting them know what's going on with you, uh, letting them know what changes are going on in your organization, so that they know you're still there and you're interested in working with them. They have needs, and just as in normal times, you want to be able to understand their needs and better respond as an organization to those needs. Also, look for market niche needs that maybe you weren't attending to before. Maybe you didn't have to. Now that you're really desperate for more beds being filled, you might be more accommodating for people, say, with behavioral issues. There's nothing wrong with taking patients with behavioral issues if you appropriately plan for caring for them, you staff for caring for them, you prepare your staff for them, that's a significant need. A lot of geriatric patients have comorbidities of psychiatric as well as dementia illnesses, and developing a program to better meet their needs is going to help improve a big pain point for the hospitals, as they typically have trouble finding beds for those patients. So that's something, rather than resisting it, embrace it and do it well. And it may be a great source of improvement for your facility. Also, really address your public image problem. And I know in long-term care, we always have a negative image. I think a lot of times it's because, at least in hospitals, people get better, they go home, the babies are born there, things like that. Nursing homes are often associated with end-of-life care. Things aren't so happy. And also, people, when they put their loved one in a nursing home, it's sometimes they see it in themselves as a sense of failure. They weren't able to take care of their loved one at home, and they're now having to resort to a nursing home. And how could you possibly take care of them as well as they could? So you need to, try to change those images. Get out messages and stories about things your staff have done above and beyond for your residents. There's many of them. Look at how you're helping your residents communicate with their family members during social isolation and promote those. Those are important things to get out into the community, get out into the media. Use these government funds wisely. Develop a project plan incorporating each government program. So for instance, when I work with clients, we usually set up a program plan for PPP funds, one for the HHS funds. If they have disaster funds, we set up another schedule for that. Because you want to avoid double dipping between the programs, and you want to show compliance with program requirements, and you want to track the jobs that you create or the jobs that you help to retain. And as you know, there's going to be for the HHS funds, there's a reporting requirement that is going, you're going to have to file a report by the end of the year on how those funds were used. And finally, look at your capital situation, assess your capital situation, and develop a longer range capital plan. One of the things we see when facilities get in financial trouble is they end up using operational funds to cover capital expenses. So for instance, the roof gets a major leak, or windows go, or some of the PTAC units in the windows, the HVAC program has trouble. And so you end up using tens of thousands of dollars of operations money for a capital expense because you don't have access to capital. So you have to look at, do you refinance? Do you look for bridge funding? Do you factor some of the receivables that you can't receive, like you're having trouble collecting on? Develop some sort of longer range capital plan for making sure that you have the revenue that you need coming in, or the access to capital to address some of these capital requirements. Now, if you can't really come up with a viable way of getting capital for your facility, perhaps then you need to consider merger or sale if you can't do that. Because you don't want to get into a position of urgency where you're desperate to either sell the facility or close the facility because you don't have enough time to really opportunize the best option for your facility. So if you really are restricted from access to capital for whatever reason, and you're not going to be able to sustain the facility in the long term, then you really need to consider merger or sale. Or also bankruptcy may be an option, although bankruptcy is not necessarily as inexpensive as one might think. It's actually an expensive way of restructuring. The important thing is to get good solid advice earlier on. Don't wait till things get desperate at the end. This has been my micro presentation. If I can give you any more information on any of the topics I touched on, please feel free to reach out to me. Thanks very much for your interest.
Thank you all so much. Visit our virtual booth. If you just search Grassi Healthcare Advisors, you'll be able to find us. And Joe will actually be there manning our booth, so please come and visit. Have a great conference, everyone.